Hi, I'm Dr. Kathryn Lindley, and I'm one of the adult congenital heart disease specialists at Barnes Hospital and Washington University. I also run the Center for Women's Heart Disease at Barnes Hospital and Washington University in St. Louis. Today, we're going to be talking about pregnancy and contraception in women with a Fontan circulation. You might think that it's not time to start thinking about pregnancy and contraception until you reach adulthood. However, this is really something that is important to start thinking about early on. Normally, the way things should work is you're diagnosed with congenital heart disease as an infant or maybe even before you're born and taken care of by your pediatric cardiologist all throughout childhood. Then, between the ages of 18 and 21, you transition your care over to an adult congenital heart disease specialist. During that time, we ensure that your heart is healthy and prepare you for pregnancy. We can then hopefully help get you through a healthy pregnancy and end up with a healthy mom and baby. However, unfortunately, we know that up to 63% of patients with congenital heart disease have a significant lapse in care between when they're seeing their pediatric cardiologist and when they transition over to see an adult congenital cardiologist. We also know that pregnancy is one of the more common reasons why women often return to congenital heart disease care, and that occurs in about 12% of cases. Therefore, given the fact that many of these patients have a significant lapse in care and don't come back to see us until after they're pregnant, these conversations should really begin during childhood or adolescence between the patients, their parents, and the pediatric cardiologist, and then continue on into transition to adult congenital heart disease care. The way we normally think about planning for a pregnancy for women with congenital heart disease is to first start with contraception counseling. We help identify methods of contraception that are safe for their particular congenital heart disease condition, as well as effective in light of their underlying risk for complications with pregnancy. When a woman's starting to think about pursuing pregnancy, we use some preconception imaging and testing to evaluate if there's anything that needs to be intervened upon with a heart catheterization or a surgery or any other type of procedure to help improve their risk of pregnancy. We then do a pregnancy risk assessment to help determine how safe or risky pregnancy would be for the individual patient. We evaluate all of their medications to see which medications might be unsafe for the baby during pregnancy, and we can make some adjustments to switch them out for other medications that are safer during pregnancy. We also talk about the risk to their baby of having congenital heart disease or other complications of the pregnancy. And then we proceed with having a planned pregnancy. When we're thinking about the risk of an individual woman planning to undergo pregnancy, that can be really quite varied. One way that we think about pregnancy risk is based on something called the World Health Organization classification of pregnancy. And this can range anywhere from class 1 to class 4, where class 1 is for women with heart disease who have no significantly increased risk of pregnancy complications than the general population of women who don't have any underlying heart disease. Class 2 are patients who have a small increased risk of pregnancy complications related to their heart disease, but it's still a small risk and pregnancy is considered acceptable. Most women with a Fontan circulation are considered World Health Organization class 3. This means that pregnancy does carry an increased risk of cardiovascular complications, and it requires expert cardiac and obstetric care. It does not, however, mean that pregnancy is not an acceptable option, but it just means that it requires really coordinated care with doctors who are really familiar with Fontan physiology and have a lot of experience in taking women with this sort of heart condition through pregnancy. Now, some women with a Fontan circulation would be considered World Health Organization class 4. Women are put into World Health Organization class 4, meaning that pregnancy is not recommended due to excessive increased risk if they have certain complications related to their Fontan repair. Those complications include things such as severe dysfunction of the single ventricle or failing Fontan physiology. And what we mean by that is very reduced functional capacity, so very limited functional ability, low cardiac output, so the heart is not able to maintain adequate blood flow to the rest of the body organs, certain complications such as protein-losing enteropathy or plastic bronchitis, and women who have significant liver failure. Now, when we think about what are those complications that a woman might experience as she goes through pregnancy, well, although the risk of death is actually very low, there are quite a few different cardiovascular complications that could arise. Those include things such as arrhythmias or heart rhythm problems in about 1 in 10 women. It includes heart failure, which means fluid retention or worsening shortness of breath in about 1 in 25 women. About 1 in 20 women will experience a thromboembolic event, meaning a blood clot development, which could travel to the lungs or the brain, in about 1 in 20. And then bleeding complications, particularly after delivery, are quite common and occur in about 1 in 4 women. So once we've assessed a woman's risk and determined that we think it would be reasonable to start evaluating for her to proceed with pregnancy, we do a pretty routine set of evaluations for a woman with a Fontan. So that would routinely include an echocardiogram to assess her cardiac function, some laboratories to assess for things like anemia, thyroid abnormalities, liver problems, kidney problems, and a liver ultrasound to assess for any problems with the liver function. We might also consider some additional testing in some certain women. That might include a cardiopulmonary exercise stress test. We might consider this in women for whom it's not really clear how much exercise they're able to do. We might consider a heart catheterization in certain women. It's generally recommended that women or all patients with a Fontan undergo a heart catheterization about every 10 years. So if there's any concern about the function of the health of the Fontan, or if it's been a long time since a woman's undergone a heart catheterization, then we might plan to proceed with that to assess for the health of the Fontan circuit. And we might consider an endoscopy or evaluating the stomach and the esophagus in women who appear to have significant liver problems. The reason that we have women undergo these different evaluations is so that we can identify any high-risk problems, and oftentimes then we can treat those problems before pregnancy to reduce the risk of the pregnancy itself. We also want to go through a woman's medications to help discuss with her what medications are safe for her to continue during pregnancy, which medications are unsafe and might need to be substituted for another safer alternative. So medications that we like to avoid during pregnancy include things like the ACE inhibitors, which may be medicines such as lisinopril, enalapril, quinapril, the ARBs, which include medications like valsartan or losartan, the aldosterone antagonists like aldactone or eplerenone, and all of the anticoagulants are generally avoided during pregnancy, all of the oral anticoagulants such as warfarin and the newer anticoagulants such as Xarelto, Eliquis, and Pradaxa. Also, the newer medication Entresto, which includes an ARB in it, is not recommended during pregnancy. However, most other cardiac medications are actually considered relatively safe during pregnancy, and we'll usually continue those medications throughout the course of the pregnancy in order to help maintain a healthy heart. That includes medications such as beta blockers like metoprolol or carvedilol, aspirin, calcium channel blockers like diltiazem or verapamil, diuretics such as furosemide, Lasix, or torsemide, and heart rhythm medications such as sotalol or flecainide. Digoxin is also considered safe to use during pregnancy. We also want to talk to women who are considering pregnancy about the risk of congenital heart disease in their babies. So we know that the babies of parents with adult congenital heart disease are at increased risk of having congenital heart defects. In general, the general population carries a risk of about 1% of having a baby with a congenital heart defect. Or if a father has a congenital heart defect, then their baby carries about a 3% risk of having a congenital heart defect. Whereas when the mother is the one who has a congenital heart defect, that risk to the baby is about 5%. There are certain genetic conditions that carry up to a risk of 50% of transmitting to the baby. So for those patients, we might consider genetic counseling as well. So because of this increased risk of having a baby with a congenital heart defect, we recommend that all babies of parents with congenital heart disease undergo a second trimester fetal echocardiogram. So what are other risks to the baby? Well, the biggest risk is really of miscarriage. Unfortunately, many women with a single ventricle do have a hard time becoming pregnant, or they have a lot of issues with fertility. And if they do become pregnant, about 50% of those pregnancies will end in miscarriage, which can be a really difficult thing for women to undergo. There's also an increased risk of stillbirth of about 5%. Most of these babies also end up being born preterm in about 60% of cases. And the babies also tend to be small in size as well. So about 20% of them will have growth restriction. Next slide. So let's talk a little bit now about once a woman does become pregnant, about how we might think about managing that pregnancy. So the way that we're going to think about managing mom throughout pregnancy is first and foremost with multidisciplinary congenital heart disease care. This is going to require expert contributions from adult congenital heart disease cardiologists, maternal fetal medicine specialists, obstetric anesthesiologist, and sometimes even cardiac anesthesiologist. We're also going to be including members of your pediatric cardiology team because they're going to be involved with helping do the fetal echocardiogram. Sometimes we also include members of the neonatology team if it appears that the baby is going to be born preterm. The woman is going to be very carefully monitored throughout the course of her pregnancy. She'll be seeing her adult congenital cardiologist at least once per trimester, sometimes more frequently, and she'll have an echo and labs and a cardiology visit at each of those visits. During the second trimester, between the weeks of about 20 and 22 weeks gestation, she'll undergo a fetal echocardiogram to evaluate her baby's heart. And then she'll also be undergoing growth scans about every 4 weeks to assess the baby's growth because of that known risk of having small babies for women with single ventricles. We also here recommend that moms with a Fontan circulation be on aspirin and low molecular weight heparin throughout the course of their pregnancy to try to help prevent that risk of blood clots. And we typically recommend delivery by about 37 weeks of gestation, and we strongly recommend that women deliver to an expert center that has adult congenital heart disease specialists as well as maternal fetal medicine specialists who have expertise in taking care of single ventricle patients. So what might you expect when it comes to delivery? Well, we typically recommend an epidural for all of our patients with congenital heart disease. The epidural really reduces the stress hormones and the effect on the heart of going through delivery. So we typically would recommend an early epidural for all of our single ventricle patients who are laboring. And we would have all of our patients with the single ventricle to be on telemetry or heart rhythm monitoring during the course of their labor. We typically recommend a vaginal delivery for most patients unless there is sort of an extreme situation where we think they're extremely high risk due to some complication of their Fontan circuit. Or sometimes there are, of course, obstetric reasons why we need to have a C-section, such as the baby is not head down. Sometimes we recommend what we call an assisted second stage, which is where we use a little vacuum suction cup on the baby's head or forceps to help assist with the pushing stage of the delivery. We recommend that moms with a single ventricle stay in the hospital for about 3 days after delivery so that we can watch them very carefully for any complications after delivery. And then we have moms stay on their low-dose aspirin and the low molecular weight heparin for at least 6 to 12 weeks after delivery because that risk of blood clots remains high even after the baby's born. It's also really important for young women to start thinking about contraception counseling. Now, it's really never too young to start thinking about this topic. We know that about 26% of adolescents with congenital heart disease report ever having sex, and 74% of young adults with congenital heart disease report ever having sex. And the first sexual activity was at age 15 years old or younger in about 15% of congenital heart disease patients. So basically, even though patients with congenital heart disease are living with a chronic illness, their patterns of sexual activity are really not significantly different than other teenagers and young adults. We did a survey of our patients in our adult congenital heart disease clinic several years ago, and we found that unfortunately about a third of all women had had at least one unplanned pregnancy. And in fact, those women who fell into the World Health Organization Class 4 category, who had absolute contraindications to becoming pregnant or absolutely should not become pregnant, half of those women had had at least one unplanned pregnancy. So it's really important that we start thinking early on about effective methods of contraception. So there's really two important questions to think about when we're thinking about contraception. Number one, is it safe? Because we don't want to cause any harm. And number two, does it work? Because if it's a safe method, but it doesn't work, it's not very effective, then that's still not achieving the goal that we're hoping for. So the main concerns when it comes to safety are with regards to the combined hormonal methods of contraception. So that means the combined oral contraceptive pill, the oral contraceptive patch, and the vaginal ring. So all three of these methods of contraception contain estrogen, and the estrogen within the method of contraception increases the risk of blood clots. These are generally not preferred for women who have a single ventricle or Fontan circulation, because we know that women with a single ventricle are at increased risk of forming blood clots, and they can become very sick if they do form a blood clot. Now, it's important to recognize that these methods are actually still safer than pregnancy. The risk of a blood clot while on birth control is still lower than the risk of a blood clot during pregnancy. So if there's no other method of contraception that is acceptable to a woman, this is still better than no method. But there are other methods of contraception that are preferred over these methods because they are safer. We also need to think about how effective is the method of contraception. And we can typically think about this in terms of 3 tiers of effectiveness. Tier number 1 has a failure rate of less than 1% and per year. And that includes permanent sterilization like a vasectomy or a tubal ligation, or the long-acting reversible contraceptives, which we'll talk about in a minute. Tier 2 are the methods that have a failure rate of about 6 to 12% per year. And that includes the combined hormonal contraceptives such as the pill, the patch, and the ring, as well as the progestin-only contraceptives. So that includes the oral progestin-only pill, or what we sometimes call the mini pill, as well as the Depo-Provera shot. So those have a failure rate of 6 to 12% per year. And then tier 3 are the methods that have a failure rate of 12 to 24% per year. So very high failure rate, and those include the barrier methods such as condoms, as well as withdrawal and fertility awareness. Now, if a woman is not using any method of contraception, there's typically about an 85% risk of becoming pregnant within a year. So let's talk about the long-acting reversible contraceptives. These are methods, as I mentioned, are highly effective. There's a less than 1% failure rate per year. The nice thing about them is they're also completely reversible as opposed to the permanent methods of contraception, such as a tubal ligation. There are basically 3 different types of methods that fall within this category. On the top, you can see the hormonal IUD, and there are several different brands of hormonal IUDs now, and they basically elute a very low level of a progesterone compound, which basically just affects the uterine lining, but it doesn't have a lot of effects on the rest of the body. The nice thing about this is that it, for many women, it reduces the amount of menstrual flow. So this can be a really nice option for women who have heavy periods, particularly if they're on blood thinners. Now, in the middle picture, you can see the copper IUD. This method has no hormones at all. It's just copper. And this method is effective for 10 years after it is placed. And the main downside to this method is for some women, it can increase their menstrual flow. So I typically do not recommend this method for women who are on blood thinners. And then the last method is the subdermal implant, or the Nexplanon. And it's basically a small plastic rod that goes underneath the skin in the upper arm. And this method is effective for 3 years. And it's a very low level of progesterone. And really the main side effect with this method is that about 20% of women will have sort of irregular spotting and bleeding, which can be irritating. And so about 10% of women will end up discontinuing that method because of the irregular bleeding pattern. Well, all 3 methods are very safe. The risk of a major complication from getting an IUD is less than 1%. And although you might have heard stories about perforations from IUD, the risk of that is extremely low. It's less than about 1 in 1,000. Unfortunately, very few teenagers and adolescents are actually using these long-acting reversible methods. But the great news is they're actually safe for all women with congenital heart disease, including women with Fontan circulations. And they're very reversible and they're highly effective. So for that reason, my recommendation is that if women find them to be acceptable, they should be considered for all women with congenital heart disease. Recently, the American Academy of Pediatrics, as well as the Association of or the American College of Obstetrics and Gynecology have also recommended them for all women, including teenagers and women who've not yet had a baby. So to summarize, most women with a Fontan can safely undergo a pregnancy. However, women with a single ventricle require lifelong care by a congenital heart disease specialist, including during pregnancy. And this allows us to optimize her health and really to help result in a healthy mom and a healthy baby. It's also really important that we start thinking about pregnancy and contraception early, and highly effective contraception is recommended to help prevent unplanned pregnancies. I think the key is to have a planned pregnancy so that we can really optimize health for mom and baby. Thank you very much.